Hi, welcome to the Golden Years, Understanding Better Living. I'm Phyllis Amon, your host. Today we are pleased to have two guests, Dr. David Chess and Morty Eisenberg from Tapestry Telehealth. They have worked together for a number of years to change the way frail seniors receive care. Welcome, gentlemen. It's so great to have you here.
Good afternoon.
Thank you for having us.
So, my first question is about Tapestry Telehealth. So, can you tell our viewers what telemedicine is all about?
Telemedicine is not one thing. There's lots of different varieties of it. What we do, where we see real value, is really trying to bring the doctor, the nurse practitioner, your clinician to the bedside, to the patient. As we get older, frailer, more things happen. This running back and forth to doctors, emergency rooms, takes a real toll on people. And so as much as possible, we're trying to get timely care basically in your home, in the nursing facility, and by doing so, keep people well, keep people from needing hospitalization. So that's really how our approach to telemedicine.
Oh, that sounds great. So you said nursing homes and you said home care. Are there other facilities that are using telemedicine?
So again, there's a variety of applications. So here in Connecticut, the penetration of telemedicine in nursing facilities is very low, and the penetration into people's homes is even lower.
Really?
So it is not taken a lot of hold here. The type of telemedicine that you'll find in nursing facilities here is an after-hour type of telemedicine. So if someone's sick in the nursing home, the nurse would call their doctor, and typically without telemedicine, when they call their doctor, often it's not their doctor anyway, it's a covering doctor.
Right.
So what happens? The doctor says send them to the hospital.
Right.
Because they don't know the patient, then they don't know the nurse, and they're not going to take any chance, so they just say send them.
Well, that makes sense.
I think more broadly for the consumer, though, the words telemedicine, telehealth, they've been kind of bandied about for a while. Sometimes they're used interchangeably. They mean different things. Telemedicine's been around for the military for a very long time. You think of your robotic surgery, Da Vinci, that type of program where you have a remote surgeon taking care of a patient on a battlefield or even in a remote hospital. That's one application. You have an application of just a nurse monitoring somebody's blood pressure from afar. You have, the consumers now have the ability for many insurance companies to actually pull an app up on their phone and see a physician who can diagnose an ear infection or a strep throat.
Right.
So there are many applications to telemedicine and telehealth. The area that we chose to focus on in our expertise is really taking care of chronically ill individuals with more of a primary care relationship, whether they live in a nursing facility or even in the home, and that's something that's starting to become more and more prevalent, and especially now as regulations change and these become services that Medicare covers in the home, we're going to see more and more of that in the home, most definitely.
So if a person was in their home, would it be that their insurance provider would have to approve these services, or do you coordinate with insurance providers to provide that service, or how would they have access to that if they were home? How would they know about it?
So on the basic commercial plans, many commercial plans for just regular services cover telemedicine in some form. And there are some large national companies that will sort of facilitate a visit for a member in the home. And many of the insurance companies are actually, promoting this because it saves a lot of money for the healthcare system.
Right.
And it saves unnecessary visits to the emergency room and things like that. So they've been promoting that sort of commercial telemedicine for quite some time now, and there are some very large companies doing it. What is kind of missing in that picture is the ability to do the same thing for chronically ill individuals. You can't really do that when you're seeing patients one-off for a strep throat or a flu, there's no real relationship built with the patient. There's probably a different doctor every time. We call it the doc in the box. Every time you call, you get somebody else.
Right.
When you're taking care of somebody that's chronically ill, that's not necessarily the best solution.
Right.
What we've done with Tapestry is build a program around primary care where, whether it's in the nursing home or in the home, you're establishing a relationship with a patient. So if a patient, for example, has chronic heart failure or something like that, and they need to be seen multiple times a month, the practitioner gets to know that person and then can hopefully keep them out of the hospital or even out of the nursing home,
Right.
Down the line.
Yeah, that's really terrific, and possibly even save them, like you say, trips to the emergency room or to the hospital. But we were talking before the show about many hospitals don't have certain specialties available at all times, like a neurologist if a person has a stroke. So how are hospitals using this kind of technology?
So along those lines, most hospitals now have teleneurology, so that if someone comes in with a suspected stroke, within moments they could have a neurologist on the screen doing an evaluation for that patient.
That's terrific, right.
And then determining how to best treat that patient. Because if you're going to treat someone with a stroke, you have to do so quickly.
Right.
So that's an application.
So yeah, I guess it would be helpful, let's say, when they're diagnosing a stroke, there are different kinds of strokes, because that could save a person's life. We were talking about that beforehand also.
So, New York Presbyterian in Manhattan, and I think there's some others around the country, actually recently launched a stroke ambulance where they have a large ambulance that's actually outfitted with a CT scanner, and the staff that are on the ambulance can actually put a patient that is having stroke-like symptoms into the scanner, kind of get a good CT of their head to determine what kind of stroke they're having. And that will make a very big difference at determining what kind of treatment they can actually render right there in the field. And they're using telemedicine to communicate with the stroke team back in the hospital.
That's great, yeah.
Right.
So I think that would probably give people some peace of mind as well, some comfort level.
Absolutely.
Because, as we all know, sometimes it takes time to get to the hospital, and what happens in that time between the time they get you from your home to the time they get to the hospital. So that's terrific.
Right.
What other, so you said that in Connecticut it really hasn't taken off in the home as much, or even in facilities. What about in other areas of the country?
So we've been focusing a lot on rural America. So in rural America, the ability to actually get a doctor to come into a nursing facility, period, to have nurse practitioners, is very, very difficult. There's just a tremendous paucity of professionals. And so what happens to people is that they then have to travel for an hour to get help, at least. I mean, if you want consultation, it can take you months to get an appointment.
Right.
And so what we've done is focused on these rural nursing facilities where the doctors come in maybe once a month. There are facilities where the doctors even never come in, and they have to take the patients and transport them to the doctor's office. So you take, again, medically frail people who often have advanced dementia. They've got all kinds of medical conditions.
Right.
You're putting them in a van and traveling, for 40 minutes.
Right.
So it's just not healthy for a healthy person.
Right, let alone for somebody who's more frail and confused,
Right.
and that just exacerbates the whole situation.
So
and makes it worse.
what we do is we contract with these nursing facilities, provide them with this telemedicine unit, state of the art, built on a treatment cart that allows the doctor or nurse practitioner to see the patient by, like a Skype type of visit.
Okay.
And then it also has a state-of-the-art digitally enhanced stethoscope. So 1,000 miles away, the doctor can be listening to your heart and lungs.
Wow, that's tremendous. Technology is really incredible,
right? We have an otoscope. We can look at your ear, see if you have earwax from across the country.
Oh my goodness, that's really pretty incredible.
There's a wound care camera. So you could do a pretty good examination, and we always work with a nurse on the other side of the camera in the room.
Okay, so there's somebody there to assist the person, make them feel comfortable, and help them move, or...
Exactly, helps us with the exam, helps us communicate, and becomes our liaison in the process. And by doing that, it has an extraordinary impact on keeping people from getting sicker. We did a study in one facility where the mortality rate, the death rate, actually went in half.
Wow.
Over a 6-month period of time.
That's incredible.
I think it's also important, when people look at technology, people think it's like sort of a gimmicky thing. You're going to bring a doc on a computer, he's going to see you from afar. We know that the care that's being rendered is real, it really works. But if I had to put one word on it or one term on it, I call it the great equalizer. Telemedicine allows us to bring resources to places that they're not available. And that can be
Right.
Bringing an emergency room to a nursing home, that can mean bringing a neurologist 200 miles to a nursing home. That can mean bringing a surgeon to a hospital. That can mean bringing a dentist to a remote, remote area that doesn't have dentistry. A speech therapist to a an area
Near
that is
and dear to my
underserved.
heart, as I've said before, I'm a speech pathologist, so that's always something that's near and dear
So
to my heart.
the technology is the enabler to allow us to bring great clinical care to wherever these underserved areas. It's not a gimmick. It's very real.
And it really is the clinician on the other side. So you have to have the right people.
Right. It's not quackadoc, as I call it. I mean, it's a real licensed practitioner who's expert in their field.
Absolutely.
Right, because these people have to be credentialed, I would assume, the same way they would if they were on staff at a nursing home facility or a hospital. Correct?
That's right.
We have a wonderful story that we love to tell, but one of our nurse practitioners was seeing a patient in a remote Pennsylvania facility, and this woman was near end of life. She had some issues, and she was seen a lot because of her issues, and they kind of developed a relationship. Again, they're a few hundred miles apart.
Right.
And the patient who, she mentioned to the NP that was seeing her that she would really love to go to a casino before she died. And one weekend, the NP drove from her home in Pennsylvania, a number of hours away. With a nurse, they took this woman out. They took her to the casino.
Oh my God, I have the chills.
It's
I
an
really
incredible
have the
story.
chills from top to bottom. I really do.
And I think they ended up going twice, and then she passed away. But what's incredible about the story is when people tell us, "Oh, this is just like quackadoc or doc in the box," you can't make this stuff up.
No,
this is
absolutely.
And I just want to add that patient won $2,500.
Oh, hey, listen, can I find out what casino she went to?
I'm happy to tell you that.
That's a good thing, right? It could have maybe hastened her demise if she lost $2,500, but we won't go there.
No, but the relationships are just key. And one of the wonderful things, again, telemedicine is just the pipe to get a clinician to the bedside. That to me is everything. The magic is being timely, right?
Right, absolutely.
Is I'm not feeling good now. I don't want to wait. Well, I don't want to go to ER. Maybe it'll get better, right? Imagine you just press a button, or you pick up the phone, you call, and then within moments you're being seen, right? It changes everything.
Absolutely. I'm thinking, I come from the skilled nursing facility space. I've said it many times. I've worked in over 40 of them, and of course I can imagine how helpful this would be, even in urban areas where, like you say, even if it's a large building and they have nurse practitioners, and the nurse practitioner, I've worked in buildings with 15 floors, and maybe they have 2 nurse practitioners, but maybe one is on floor 15 and you're on floor 7, and it takes however long for the nurse practitioner to get to you. This would be really terrific.
You talk about specialists. Even the largest building in the middle of New York City, they may only have a few residents, patients that have a need for neurology, for example.
Right.
The neurologists don't want to come to those buildings. It's difficult. It's not worth their while. And we can bring that in using telemedicine, even in the urban areas. And again, it's just 2-3 visits or whatever it may be. But now you're bringing state-of-the-art care right to the patient without taking them out, and it's a few-hour ordeal at best.
It's really like bringing a whole medical team. So imagine we're in some nursing facilities in remote areas that maybe have 30, 40 patients. They're small. Imagine we're bringing this whole medical center to them. So we provide cardiology, pulmonary, infectious disease, endocrinology, neurology, wound care, psychologists, psychiatric nurse practitioners.
Speech therapists.
And we're working on speech therapy.
Dietitians, social workers, you name it, really.
So it really gives them resources that they would have no way of having otherwise.
It's funny that you say that. It just brought something to mind when we said speech therapy, is that years ago I worked for a company that owned many facilities, and the person who was in charge of rehabilitation for that company, because I used to go from place to place sometimes. They need me here and need me there. And he used to say to me, why don't we just, put the person in front of a TV screen, and, you could even see multiple people at the same time, and whoever really envisioned that would really happen. But here we are, so it's really great. I thought about having you guys on here, especially when I saw this commercial that, it's a commercial that, is it the VA, I think, that's partnering with T-Mobile, and they show people taking blood pressure and talking to a to a physician, I think, via Skype or some service. And so people may have seen that commercial, and that's really why I wanted to have you gentlemen on, so that people become, more understanding of what that service really is.
They're going I think the viewers are going to start seeing a lot of movement into telemedicine. CMS recently approved telemedicine as a modality for Medicare Advantage plans.
Okay, wait, let me just interject, because a lot of people might not know what CMS is.
Sorry.
So
CMS
I know, but
CMS is the government body that runs Medicare.
Okay.
And basically Medicare has approved for Medicare Advantage plans the payment of telemedicine. And what's going to happen with that, and that starts as of 2020. And Medicare Advantage plans, unlike traditional Medicare, they have these large care management teams that have a vested interest in keeping their members well and healthy and out of institutions, whatever that may be, whether it's a hospital or a nursing home.
Right.
And now that that's approved as of 2020, even in the urban markets, the large Medicare Advantage plans like United Healthcare and the Humanas and Aetnas and all these other Medicare Advantage plans are going to be pushing this service into their members' homes. And initially, it's probably going to be sort of like an incentive, instead of going to the hospital, try to get the telemedicine visit. But we think, and we've had conversations with quite a few of them, that they see this as an opportunity to really start managing the care of those that are really frail. We talk, Dr. Chess talks a lot about 5% or so of the Medicare Advantage population that has multiple conditions, and that keeps them going back and forth to the hospital.
Right, especially as people get older.
Right.
Right.
So now they may be leveraging a care management team, they may be leveraging home nursing, but now to have the ability to actually bring physicians and nurse practitioners into the home at the time that they're needed, and hopefully before they're needed. A lot of this is about being proactive about changes in condition. It's going to be a big. There's going to be a big push, and I think the viewers that are on Medicare Advantage plans, which are 35% or so of all Medicare beneficiaries and growing, are going to see a big push to telemedicine in the home in the coming years, probably starting even next year.
So how do you think that's going to affect people going into nursing homes? Because there are over 15,000 nursing homes in this country.
Well,
so we're also an aging society.
Absolutely.
And so, and no one has found a cure for dementia yet. And so I think the nursing homes will be okay in terms of filling their beds. But I think what we're going to do is continue to decrease the amount of people in hospitals. So when Morty speaks to us really having a focus on chronic care, people with chronic disease, well, it's those people with chronic disease that have a lot of acute disease. So, but you can only get in front of those people and actually manage them and care for them if you understand their chronic problems.
Right.
Of course, there's heart failure that they're having.
Right.
There's exacerbation of their emphysema.
Right.
These folks are very prone to getting pneumonia. When you have a patient with dementia, they aspirate, they get pneumonias right and left, they get urine infections, right? Those are all preventable. We can keep those people out of the hospital. The key is getting in front of them in time. And so we're in conversations with a large health plan now where we would actually, when people went home from the hospital, if they were unstable at all, they would be connected with us from the time they get out of the hospital until they're stable. And then until they're back in seeing their own doctor and following up with them.
I was just thinking that this would be a tremendous, could be tremendous peace of mind for families of older loved ones, knowing that, if their loved one is at home, that they have access, if they have even like a visiting nurse or something, or an attendant with them a number of hours a day, that they don't have to rush to an emergency room, that they have access to this kind of information, especially I even think family members who live a distance away from their loved ones. I mean, this could be tremendous peace of mind.
And speaking of families, we're able, in the nursing home, but even in the home, I guess, we're able to loop family members into the actual exam. So if you have an elderly person in the nursing home, you can bring their daughter from 100 miles away onto the same screen to help, either answer questions or just see
Wow,
what's.
that's
Right.
really, really terrific, especially for people who are older,
Right.
maybe more confused.
Right.
And I'm actually one area that I focus on a lot now is cultural diversity. So there are people who don't speak the language of the people that are caring for them in
Right.
the facility.
You could have the interpreter right on the
That
screen with
that's
you.
fantastic.
You know, back to your question about the nursing homes and whether this is going to keep people out of the nursing homes. There's been a movement already for the last number of years. I mean, we've seen it in our careers, where the nursing home of old, the Shady Acres Retirement Home,
Right.
and I'll refer to an old favorite, the County Infirmary,
Right,
how these
right.
places were called.
Right.
Those are no longer. Now the nursing home of today is the community hospital of yesterday,
Right.
and the acuity level of the patients that are in nursing homes is just going higher and higher.
Right.
And
Absolutely.
you know,
right.
as we're able to keep more of those more of the less acute patients home, the ones that truly do end up in the nursing home are much more either acutely ill or have other issues like dementia and so on.
Right.
So
Right.
there's a real need, to keep people well and keep them home, but also when they are institutionalized for whatever reason, because they're beyond the care of the home, to also have the ability to keep them in that setting
Right.
and treat them in place and make sure they don't end up, in the
Right.
hospital where nothing good comes from
So, I have another question, which is I'm thinking about assisted living facilities. Do you find them, because, in a lot of cases, those people are more independent, although some of those places really render care, a
Absolutely.
considerable amount of
Right,
care for
right.
activities of daily living as
Right.
well as other care. They
Right.
administer medications, or,
Yep.
well, the facility doesn't, but somebody is
Yep.
there to do
Yeah.
that. So do you find that assisted living facilities are starting to, warm up to this concept?
So I think the limiting factor, they're very warm to it. They really want to keep people in place. They don't want to have to send them out because then they often will lose them. They'll go to a nursing facility,
Right.
right? And so they're incentivized to keep them there. The problem is that the payment source for visits still hasn't matured unless it's in a rural setting. So if it's a rural assisted living, then Medicare will pay for it. But if it's not, then the patients themselves would have to pay for it. And so that's what has really slowed the growth in that environment. I would bet that in 2 years, all that opens up and the telemedicine is appreciated for what it can do, and becomes payable everywhere, not just in rural America.
So I would say that we need some real advocacy
Absolutely.
on that front, right?
Yeah, and it's really moved that way. I mean, typically when Medicare changes rules, they change the rules and they apply them first to the Advantage plans, because those are run by large commercial companies that have a lot of money and money's not the right word, but they have a lot of incentive to save money because it's their dollar. So they typically make these innovations apply to those companies first. And then when they can prove that the innovation works, then you see it roll out to the rest of traditional Medicare. So I think we see that, being that they've now opened up telemedicine to even non-rural areas for the Advantage plan starting next year, 2020, in a few months,
Right.
that, it's not going to be far behind, probably a year or two behind that they open it up for the rest of traditional Medicare.
So a person is in their home. How would they know? How would they start this process? I mean, how would they know about it? Would it be through their insurance company? Their insurance company would just inform them of this, but how would that work?
So there'll probably be a number of different routes to get here. So you'll be able to, the daughter may go on the web, on Google, and say, hey, what kind of help is there to keep mom at home?
Right.
And find this telemedicine service where you can have this kind of urgent care available to you. And then that patient would then get a device, and that device would automatically connect them to us and allow us to do the exams that we need to do. So that's one channel. The other channel is through the health plans themselves. And the health plans will identify those who are frail, who do keep going back and forth to the hospital, and say, you know what, we really want you to help us with these folks.
Right.
And
I think that's going to be the biggest penetration, because again, it's always about following the money. You know,
Right,
the insurance
right.
companies
Right.
are at
Well,
risk.
it's
That's the way it
all right.
is.
It's just the way
Right.
it's a fact of
Right.
life.
Yeah,
Right.
and the insurance companies are at risk. Every time a patient goes to the hospital, it costs the insurance company between $15,000 and $18,000.
Right.
Okay, they're not getting that in premium for these members, right?
Right.
So they have a very vested interest in keeping people out of the hospital, out of the nursing home, financial interest.
Right.
And when these types of modalities are approved and they start, they're able to leverage them for their sickest members, they start seeing real savings real quick.
Mm-hmm.
They're already doing it. They're already doing it with their diabetics. They have a diabetic educator. If a viewer at home has diabetes, most likely, if they're on an Advantage plan, somebody's calling them every so often and talking to them about their diabetes.
Right.
You know, if you get a prescription for an asthma inhaler, a month later you're getting a call from a nurse talking
Right.
about your asthma.
Right.
So as these things become more and more prevalent and they're allowed to include them in their basket of services, they're going to be applying them to their sickest patients. So I think the biggest push, you'll always have, people that go online and kind of get that like concierge type of medicine, but the wholesale approach to this is probably going to be the Advantage plans taking their sickest populations and saying, hey, this is an intervention we know works. It keeps people out of the hospital, keeps them well at home, allows them to live longer and manage their conditions longer, and we want you to be a part of this. And I think that's where the biggest push is going to be from.
So I have another question that I thought of because a few weeks ago I was interviewing someone and they were talking about the need for broadband in order to have some of this technology. So how does broadband factor into this?
So the first, so back in 2009, I worked in Chicago with a program that we identified people in the emergency room who were going to be admitted upstairs to the hospital. It was a very big hospital and a full hospital. They didn't have the capacity. And so we would actually take people who were going to be admitted and admit them to their home with the hospital. And they'd go home with a whole package of goods, and a nurse would go home with them. And they immediately, within 10 minutes of being home, they'd be seeing a doctor. And so we would set up a two-way video conferencing unit in their homes. And we did that on a plain old phone line.
Oh, okay.
So, so nowadays, over the last 10 years, everything has changed, right?
Right, absolutely.
Everyone has Netflix at home.
Right.
Everybody has some kind of Wi-Fi.
Right.
And if they don't, everyone has a phone. Everyone has a smartphone.
Right.
And so we can do everything we need to right through a smartphone type of device.
Oh, that's terrific. So nobody needs to worry about any kind of fancy technology or hooking their house up or apartment up in any special
I mean, there are
way.
always going to be some exceptions.
Right.
But for the most part, for the vast majority of folks who are getting cable TV and they're going to be fine.
Yeah, I mean, we've it's interesting sitting here in Connecticut. We don't even understand sometimes the dynamics of some of the rural partners that we deal with. We have, facilities and then certainly residents in areas where the internet they get is satellite. There can be large delays in the transmissions. Technical term is latency, and with latency you can have delays in video back and forth. And there have been there's been a big push to kind of fund broadband in some of these rural areas.
Right.
And there's a big push for that, and it's certainly 5G in these in the urban
Right.
areas. So as that improves, things will improve. There are certainly areas in rural America that you probably can't do face-to-face medicine just yet. But there are other ways of doing it. There are some. They call it store and forward, where you can actually take a picture, send it to the doctor, or
okay.
other things that are not necessarily real time. So again, it's really about adapting to what the realities of that place are. But remember, the alternative is a 200-mile trip to a doctor's office or whatever in the most rural areas. We're far above that.
I mean, I'm thinking as we're sitting here that the application of it is really, tremendous. Not just for people who are frail and older, women who are pregnant. I mean, the application is really tremendous.
I think theoretically we can empty out doctors' offices, right? Or the doctor's office will move. In doctor's offices, they'll have a room where they do telemedicine, right? Where they actually can do this. Because again, the point is, and having that private office is, the relationship is so important.
Absolutely.
That, but how they care for people, how they get to them, is going to just continue to evolve, and it will not look like what it looks like today 20 years from now.
You know, I was just thinking also as we're talking that, being that I'm a speech person and I'm about communication,
Right.
and face-to-face communication and people looking at each other, I mean, this could really be a tremendous help in that regard, because the person at the other end really has to be laser focused on
Right.
the person. They have to be looking at
That's
them.
right.
They have to be,
That's right.
picking up other signals that
Right.
may not be verbal signals,
Right.
very keen observers. And so they really have to be present in the moment, communicate very clearly. So I'm actually thinking that this could even be helpful in other regards.
Yeah, so it's a very keen observation, I'll tell you. So the trick, so I've done personally probably about 10,000 patient visits through telemedicine. And what's so interesting to me is human nature. So initially, when a patient sees you, a person sees you on it, they're seeing the computer, they're
Right.
seeing all this stuff. I'm telling you, within 3 minutes, the computer's gone. It's just two people talking.
Right.
And you are seeing each other's faces and seeing the nuance and picking up on that body language. The other thing that's really very helpful for us is that since we are a virtual company, we can select clinicians from anywhere in the country, make sure they're licensed where we need them to be, but really hone for people who are good communicators, who can extend themselves, because how many times you go into a doctor's office and you're not sure who you're talking to, right?
Well,
or you're talking to their back.
well, this is why I thought of it, to tell you the truth, because many years ago I had a knee issue, and I was going with someone who was seeing a doctor, and I, for something that was more serious than I was seeing them for, that I was thinking about for myself, and I asked the doctor, to take a look at my knee and what they thought. And I mean, he looked at me for a second, but really his back was to me. He was writing his notes, and now, especially when time is of the essence, doctors
Right.
have they have 15 minutes to see a patient. It's all built into a formula. It's financially based, but that's it is what
Right,
it is.
right.
And so now they are spending a lot of time not even looking at a person,
Right.
writing notes. Their
Right.
back is to them.
Right.
I don't even know if they hear everything the person
Right.
is saying. Not out of any malice, just because of the way the system is. It's just
Right.
a fact.
Right.
So it's interesting that you
Right.
say that.
This really draws you
Right.
together. It's,
Yeah, I
it's,
think
it's
that's,
incredible, the chemistry.
Is that something that we didn't really address yet? Just about, I think that some people may think or question what kind of quality of care can you get from a remote physician, and does every specialty allow itself? Like if you're going to a cardiologist or a neurologist, like does he need to be there physically to put his hands on you? And I think Dr. Chess can speak to that more than I can, but we see the primary care and certainly many of the specialties that we have in our practice that really lend themselves to remote care.
Yeah. So this last week, I was I was asked to see this patient in a nursing facility, and I'm a geriatrician, so my whole life has been taking care of older, complex people, and they were asking me to see her because she's just stiff and just not responding the way that she used to.
Mm-hmm.
And so I go there. Now, I'm not physically in the room, I'm on the screen, but the nurse is there for me. And I walk the nurse through the examination, and it becomes clear that this person has Parkinson's disease. And I then prescribe, so again, she does all the examination.
Right.
We're doing a neuro exam together.
Right.
And then I prescribe medicine. I go back this week to see the patient, and the person's a new person. She's walking.
Wow.
She wasn't walking.
Right.
Right? So by being able to bring a specialist like myself to the bedside and see and know what they're looking for and at, and this person was seen many times by many doctors before,
Right.
right? But it's being able to bring the right doctor to the right
Right.
patient
And
at the right
really
time.
and really
and
hone
focus.
in and
Exactly,
really focus
exactly,
and hone in.
Exactly.
You take like an orthopedic issue. You know, somebody falls and has a hip fracture or something like that. So the initial course of treatment is going to be at a hospital. There's going to be surgery involved. There's going to be a rehab stay. But then there's all this follow-up that has to happen that is really not necessarily that hands-on as far as the requirement of the physician, you know, actually being in the room.
Right.
You know, there's reviewing images, there may be having somebody manipulate the limb or whatever it is, but a lot of that follow-up care can be done very effectively from remote without forcing the patient to actually walk down the 3 floors of their apartment to actually get into a car and maybe fall and break their hip again.
And you know, it's interesting that you just said that because because I'm thinking when people are discharged from the hospital or nursing homes, whatever, there's always an issue, how many steps do they have to go, and will they be able to go in and out? So it would be, it's an interesting thought to think, well, if they only have to get in one time for a period of time, and then, you know, take advantage of services from another platform, I mean, that could be tremendous.
Right.
Yep.
That's really great. What about, I had another question as you were talking about that, in terms of hands-on. Oh, so you did say somebody always has to be with the person when they're being seen by this specialty. Is it always a nurse, or can it be a licensed practical nurse? Can it be a certified nurse's aide? You know, what are the qualifications of the person that has to be with them during this interaction?
It depends on the type of interaction. So if it's a neurology exam, we probably need to have at least an LPN or nurse on the other side. If it's a psych visit, we don't need, it could be a family member.
Oh, okay.
Could be on the other side. If it's for a routine follow-up for heart failure, may just need to be a family member with that patient, because all we need them to do is help us with the stethoscope, right? And we'll tell them, put it on their back. Let's take a listen. Right. So, because what we want to do is make this as accessible to the patient as possible. The more we have to have another specialist of some sort, another individual on the other side that's not naturally there in that home, the more delays you have.
When you get into the home, though, when people are living at home, they're more independent generally. A lot of the exam can be, you know, a self-exam.
That's true.
You know, a lot of it's history taking and description of symptoms and you know, things like that. And to stick a stethoscope on your chest. They even have now a glove that has EKG leads in it that the patient could just be instructed to put like that on their chest.
Wow, and it will...
It'll give them a full 12-lead EKG from wherever.
Oh, wow, that's phenomenal.
You know, so if somebody is at risk for that sort of problem and you discharge them with the tablet, let's say, and the heart, I think it's hand over heart they call it, glove, you know, it's really self-serving in some sense.
So I was thinking this when we were talking about, let's say, a hip fracture, and let's say you don't really need to go to the doctor to just have him look at the x-rays and see how it's healing. How does that affect cost? Because, you know, we all know you could go into a doctor's office and be there 10 minutes and it's $350, but, you know, you're not just paying for the 10 minutes, you're paying for the expertise. But how does the cost, you know...
Theoretically, this can markedly decrease your costs. So, and it does already. Again, every time you prevent that admission, it does. In these other specialty type of visits, where you don't have to have that massive overhead of your office, you don't have to have, you know, 3 people that you see before you actually enter the room. Right. It has a tremendous potential impact.
And a lot of the prep work people don't realize, but there's a lot of mobile X-ray and mobile lab, and they can do an echo in your house. They can do a chest X-ray in your house.
Are they starting to do that? I mean, obviously they go to skilled nursing facilities and do that. Are they doing it in people's homes?
They do that, you know, usually in conjunction with home care. So if you have somebody that's homebound and they're getting skilled nursing at home, you know, they have these mobile companies that come draw their labs every week, and they have companies that do X-rays and so on. So if it's non-emergent, and let's say, for example, somebody needs a follow-up for a hip fracture, there's no reason to not have that stuff lined up. And then the remote practitioner can see the images, and go on from there. So, you know, there's a lot of ways of doing that when you kind of rethink how care is delivered.
I mean, this has just been terrific. Do you think there's anything else that we didn't cover that you think it would be important for viewers to know?
So the other thing that we're working on is actually around biometric tools, and what that means is glucosometers. So you're diabetic and you check your sugar. Well, who's tracking those, right? So we have a device that we've been working with that we give to patients, and we're doing it in nursing facilities right now. That we're checking their sugars and seeing what the levels are every day. We're looking at trends. Are you going up? And then if there's an outlier, if your sugars are really high, we're calling the facility and saying there's a problem, we need to get involved, or the blood sugar is really low. And so we're able to prevent, again, a lot of mishaps and work to get the person's sugars under good control. And that obviously is life-saving as well. So that's another application of what we're doing in this space. We're looking to do the same thing with oxygen measure, oximeters, which measure oxygen. So again, people at home won't be as alone. Someone's going to be watching them through all these devices.
As somebody who, my specialty for years were people who were ventilator dependent and with trachs, I just got the chills when you said that because it gives somebody such peace of mind, especially when you're, when you listen. Either if you don't have enough oxygen, you're not breathing. We know what the end result of that is, and I know from working with people in that situation how fearful. I mean, and that produces more anxiety, which obviously makes it more difficult for you to breathe. So that, I'm thinking in and of itself would just be tremendous.
And so we're hoping to be able to package all these things and eventually bring it into the home, and we're packaging it now and bringing it into nursing facilities.
Oh, that's terrific.
I think something to keep in mind. I think there was a recent news story that got a lot of traction about a physician who informed somebody that they were going to die over telemedicine, and this was a huge uproar. This is a few weeks ago.
I think I read this.
It's been
article.
all over,
yes,
and it gives a really kind of a bad rap to telemedicine. But this doctor, obviously, again, I don't know him and I don't know the circumstances, but he may have done that same presentation right in front of the patient. And they kind of, it kind of paints the picture that this telemedicine is this impersonal relationship, and this doctor just came into the room and told this lady she's going to die tomorrow, and it's so impersonal, and the world's coming to an end. And it's really, it's a sad story. Nobody should find out about terminal illness like that, but it really does a very big disservice because telemedicine is here. It's been around for a while, and it's going to be more and more prevalent as we go forward. It's an amazing treatment modality. It brings services and resources to places that couldn't get it before. Saves a lot of anxiety, time, illness, and just exacerbation of illness. So I just want to you ask for a last thought. You don't want I don't even want to use the word industry, but the treatment option of telemedicine to be kind of painted by one or two news stories where something went wrong with telemedicine. It's really about the practitioner on the other side.
Well, I was just going to say, to tell you the truth, through my experience working in many facilities with many different doctors and practitioners, I mean, some have better bedside manner than others, and I've had that experience. Listening to it, or have families tell me that this was said to them. So, like you said, it has to do with the practitioner, not with telemedicine.
Right, exactly. I've had many, many conversations through telemedicine about end-of-life conditions and about trying to help people figure out what they want, and so that we give them the appropriate care. But it's a very, it's a very personal conversation.
Right.
It's a very difficult conversation at times.
Right.
But
even in person.
Even in person. But if you avoid it and you don't have the conversation, then that person doesn't get the care that they actually want.
Oh, I agree with you 100%. I just will say, many years ago, when I was working on a vent unit, actually, and if I could just tell this little story, it just made me think of it. So there was a patient there, and his daughter was there, and it was somebody who was on a, I think he was ventilator dependent, or maybe he had a trach by that point, and they asked a question about if he wanted the trach to come out, and they asked a question of the doctor, and we were doing rounds at the time, and he told them in a very compassionate, nice but honest way what he thought would happen if that were to occur. And as practitioners, we had never experienced a doctor say that to somebody before, and it really took us aback, but the reality was it was an important conversation to have if it's said the right way. So it goes back to what we're saying about the personality, the bedside manner, compassion, the feeling for that person, which having nothing to do with telemedicine.
Right. You're gonna have people who are rude or uncaring.
Correct.
Physically in the room,
Right.
and you could have them on the other side of the screen.
Absolutely. Well, this has been just terrific. So how would people get in touch with you?
Well, we have a beautiful website, tapestry.care.
Okay.
And it's not .com, .care. And,
I like that.
Yeah, it's very nice, and there's contact information on that site.
So it's tapestry, TAPESTRY.care.
Correct.
Okay, terrific. And I'm sure there are phone numbers and,
Yep, everything's there, and we'd love to hear from your viewers and see how we could help.
Oh, it's terrific. Thanks so much for coming. I'm
Well, thank
sure
you.
it's been just
It's been a lot of fun. It's a good
tremendously
conversation.
valuable, tremendously
you.
valuable
Right.
for people. So thanks for tuning in today. Hope you enjoyed the show. This is Phyllis Amon saying goodbye until we see you next time on the Golden Years, Understanding Better Living.